Welcome everyone to this webinar hosted by NIHR School for Social Care Research. My name is David Abbott from the University of Bristol, and I'll be chairing the session, but not doing very much because we really want to hear from our two speakers, and we will definitely keep to time and finish at the end of the hour. We're going to hear about two research projects which are at quite different stages, or perhaps at slightly different stages of progress. We're going to hear from Jill Bradshaw in Kent and Sara Ryan in Oxford. Please keep yourself on mute for now. Do use the chat function to kind of log any questions, which I'll keep an eye on. And then when it's question time, it'll be a mix of, I'll be looking out for people that want to speak and looking at the chat function. So yeah, thanks very much for coming along, and I'm going to hand straight over to Jill for our first presentation.
Thank you very much for that introduction, David. Hang on, it's taken itself off. Right, hopefully everybody will be able to see that. As David said, I'm Jill Bradshaw. I'm a lecturer at the University of Kent, and I'm also a speech and language therapist by background. And I want to talk to you today about some research that was completed last year, where we were looking at the quality of communication support for people with intellectual and developmental disabilities who are living in adult social care. And so I want to talk to you a little bit about the background about why we decided to do this research, and give you an overview of the methods that we use. And then in terms of the results, to talk to you a little bit about the participants. And so who did we talk to and why? And what did we do, and to tell you about some of our findings in terms of the quality of communication support, and then to perhaps reflect with you a little bit on what our findings mean, how we might understand our findings, and what some of those implications might be for research, for individuals, for services, for providers. So why this research? Well, we know quite a lot about the quality of communication support that people living in adult social care settings typically receive. And although there's clearly a huge variation, when you go and spend time observing, what you typically find is that staff communication is often at a level that's too complex for the people they are working with and supporting. And so typically what you will find is that staff will use more words, more complex words, longer sentences. And so you might expect service users, people living in those settings, to have quite a mixed experience in terms of the quality of communication that they receive. If you have the luxury of spending time observing and watching, what you often find is that when service users, when people living in those settings use communication to express themselves, they get a response from staff around half of the time. And so half of the time, what that means is that people's attempts at communicating are missed. We know that this is a population of people who are really likely to have some significant communication challenges. And so people who are very likely to need additional support, who are likely to need signs and symbols and objects of reference, and a range of different ways of having their communication supported. But we know from other studies that very typically, most of the communication from staff is verbal. I need to make it really clear that although I am sometimes critical of what staff do, I am not critical of staff, in that what staff are always doing are paying attention to the things that they are told to do, in that they are doing absolutely the best job that they can do with the training that they have and with the resources and the support that's available. And so I do just want to make that really clear. So one of the things that I wanted to look at was, well, what happens if people are supported in settings where there's a really clear description about how people communicate and what their communication skills are? And that's one of the recommendations for good support for communication that's come out of some work that the Royal College of Speech and Language Therapists did. And one of the ways that that is happening, or one of the ways that that could be happening, is through the use of communication passports. So communication passports are tools for supporting people who can't easily communicate for themselves. And the idea is that you have one document that contains all of the information from formal assessments and make it really clear how best to communicate and interact with that individual. They provide a positive introduction to the person, and so they don't just include information on challenges and disabilities, but also on people's likes and dislikes. They should include information about the person's own views and about their preferences. And they should be presented in a way where you can really easily see how you need to communicate and interact with this person, how to present information to the person, and how to support their communication and interaction. They should include information from all of the places where individuals are spending time, and they should be easy to read, informative, useful, and fun. What was previously known about communication passports? Well, we know that parents and practitioners are really positive about communication passports. They generally like communication passports. But actually, most of the studies don't look at the impact of a communication passport. And so what happens when a communication passport is in place? And actually, all of the studies that we looked at, only 3 studies included adults. So we know much more about the use of communication passports in schools, in services where children with intellectual and developmental disabilities are being supported, and much less about what happens in adult services. So what we wanted to do was to compare people who used communication passports and contrast that with people who didn't use communication passports. We wanted to know what communication partner views of communication were like. We wanted to carry out some observations, and so to find out what actually happens in practice. So what do people say they do? What happens in practice? And we wanted to look at either existing assessments or conduct our own assessments to find out what people's communication strengths and needs were. We also wanted to talk to service users and find out what their views of communication and interaction were. And our idea was that we would have a group of people who used communication passports and a group of people who didn't use communication passports. And I guess our thinking was that if you had a communication passport, your experience of communication and interaction ought to be better. It ought to be more consistent. You ought to have perhaps a better experience. In terms of the participants, we approached 24 eligible services, and in the end, 4 services agreed to take part, and the support was provided by 5 different providers. So we had some settings that were residential homes, we had a local authority provision, we had a supported living setting. So we had a variety of settings. Within the different social care environments, we had 29 service users in total, and 10 of those were described as being passport users. We were really fortunate to be able to interview 60 staff, and those staff were perhaps more experienced than you might typically find, in that on average staff had worked in services for around 12 years and they'd been in their current post for an average of 7 years. We interviewed 5 family members, and we also were able to talk to some service users using an approach that's called Talking Mats. A little bit more information on our participants. So we had roughly equal numbers of male and female participants. We had in other ways a very undiverse sample in that most of our participants were white British. Our sample was perhaps slightly older in that the average age was 57. In terms of ability levels, we used a fairly, I have to say, a fairly crude measure. We looked at the adaptive behaviour scale, and a score of 151 or below is a measure that's sometimes used to indicate a more severe level of intellectual disability. And so most people in our sample had more severe intellectual disabilities. In terms of the sample, only 7% were described as having hearing loss, which would be incredibly unusual. I think that we would expect that figure with an ageing population to be much nearer to 50%. And so I think that probably is an underrepresentation. We were surprised that only 1 in 5 people were identified as being autistic. And again, I think that probably is an underrepresentation. And then 93% of our participants were described as having at least one behaviour that was described as being challenging. And I'd like to draw your attention to that just in terms of noting that in our observations, we saw no behaviour that was challenging other than behaviours that were so kind of more self-stimulatory. So I have to say that I come to you feeling like a bit of a failure, to be honest, because we did manage to recruit people who had communication passports, but I'm not really sure we were able to answer our research question, in that we had a problem because the quality of the communication passports in the sample of people who were in our study were generally very poor. They really were not very individualized. They were not terribly accessible, and the information on communication was very vague. And so a communication passport should give you very specific information about how you need to present information so that the individual is able to take part successfully in communication exchanges. And the information in the passports just wasn't good enough. So actually, having a communication passport didn't mean you got staff communication that was better matched to your communication strengths and needs. It didn't make a difference. And as a speech and language therapist, I was really horrified to find that if you had a speech and language therapy assessment, it also didn't make a difference in terms of the quality of communication that you received and the way that your communication was supported. Just want to tell you a little bit more about some of the findings that we had from our observations. Like lots of other research, we found that if you were more able, so if you had less disabilities, if you had more communication skills, you were much more likely to be getting much better support. And that's partly because I think we are pre-programmed to communicate verbally, and if your skills just happen to match with people who are more able because they're verbal communicators, that creates a better match. We were really concerned that only 2 people in our sample were observed to receive good support for choice, and 3 people didn't have any choice whatsoever offered during our period of observations. And we were really quite devastated to find that although staff were really clear in our interviews that people needed alternative and augmentative communication, so signs, symbols, photographs, objects, only 4% of all staff communication involved any use of AAC, and that 4% was accounted for by just 1 individual. So for most of our participants, we observed 24 in all. All of the communication would have been just verbal communication. So why is that the case? Well, we were interested in how staff had learnt about communication. How had they gained their information about how to communicate and interact? So almost always staff were getting that information from files or from other staff or from learning as you go. Now that's a great strategy if you're working in an environment where things are working really well, where the staff communication is great. If not, then what you're doing is you are learning poor practice. Only 3 of the staff mentioned getting information about communication from families, and we found that really shocking, in that families are the constant people in the lives of service users, and all of that information about how people communicate and interact and their experiences was really lost, was not coming through into adult services. Hardly any staff mentioned getting information from a speech and language therapy report. And so there's clearly a problem there in terms of the information that's contained in those reports or how it's shared. And only 2 staff mentioned training as having been something that had helped them in terms of their understanding of communication and interaction. We think in addition that there are some other issues that are likely to be impacting. And so one of those was about staff's perception of their role. And so it wasn't unusual for staff to say something like, well, I've finished all my jobs on the unit and so there's nothing left to do, so I don't really know what you're going to observe. Or, oh, I think he might be a bit bored. Now, from our perspective, the staff's job was to support and enable the individuals, but there's clearly a mismatch there because staff are clearly thinking something quite different about what their role might be. There was definitely something that was not quite working in terms of people's, in terms of staff descriptions of choice. So it was not unusual to find people saying things like, well, if you're coming to observe, they're just watching television today, but that's their choice. It's their choice to watch television. And we did watch a lot of television when we were there doing our observations. But contrast that with this next point. So here was an individual who clearly had a view and was able to express their views on what they wanted to do and who they wanted to do it with. But the attitude here was, well, you can't tell staff what we have to do. You have to wait to see who's going to take you out. So you can express a choice to watch television, but you can't express a choice around who's going to support you or what they're going to do. And there also seemed to be an element of choice around the different modes of communication that staff were using. She does use Makaton, but not many of us do. I can't sign, I don't sign. And I wondered whether you would hear the same kinds of arguments being made around medical needs. Oh, well, she's diabetic, but we choose not to give her insulin. Or around physical needs. Well, she needs a wheelchair to walk, but we choose not to do that. And I'm not sure you would. I think there's something more specific around communication and interaction. There were lots of problems around communication only being in the moment and staff feeling that they could only talk about things in the moment. Can't talk about things in the future, he'd expect it now, and then he would not stop asking for it. Now, I don't know about you, but I would find it incredibly difficult if I never knew what was going to be happening to me in the future, if I never knew when a demand was going to be placed on me. And then I'm not sure that we were always in our interviews talking about the same things. So in terms of perceptions of communication, I thought this quote quite nicely summarised. This person said, I don't have a problem communicating with him, but how much of it he takes in, I don't know. Now that to me was absolutely illustrative of the problems of communicating, because communicating is not just about what you say as a member of staff, it's absolutely about the way that that information has been received. So just to summarise, the quality of communication, including communication passports, was generally poor. And we think that's a reflection about lack of knowledge about service user strengths and needs. Even where needs were identified, people being unsure about how to address them, many missed opportunities to engage in communication and interaction, little knowledge about and also value given to alternative and augmentative forms of communication, misunderstandings about choice, lack of knowledge about the need for structure and predictability, and lots of differences in understandings about the role of staff in supporting engagement in activities, communication and relationships. And we wondered if we needed to better train and equip staff around communication and interaction, but also to provide them with better practice leadership and support to implement good communication, to really work to help staff to create opportunities for communication and interaction, to provide better information about individuals' communication strengths and needs, both from formal assessments, but also sharing that information across staff teams, and importantly, between families and those working in services. It felt like an awful lot of that information was being missed. And then just as a final point, I do wonder whether our start point was wrong, and we started thinking about communication passports and would they make a difference. But I think we needed to go back a stage earlier and to think about better ways of identifying information about service user communication, because it felt like that was the bit that perhaps hadn't been working quite so well. I'm sorry, I think I'm a little bit over time, and so I shall stop there.
No, you're not over time, Jill. Thank you so much. It's super clear, super interesting. Thank you. And I'll quickly go to some of the questions in chat, some are clarification and some are questions. One of your very first slides that had the numbers about people getting support with communication, and Anne-Marie was just asking, were they the figures from your research, or were they figures that you had got from the literature?
Those are from the literature, but previous search that we've been involved in. And if people want to email me, I'm very happy to share those references.
Great, thank you. And Donna was asking about whether the speech and language input that you were talking about, was some of that in-house? Was it from local services?
It was mainly from local services rather than from being in-house. Now, it was interesting because we looked, another part of what we did was did the file reviews, and most people didn't know that there was a speech and language therapy assessment in the file. So lots of those we found afterwards. So they clearly were not seen as being useful if people didn't even know they existed in some cases. Lots of speech and language therapy reports that were around dysphagia and swallowing that had focused on medical and swallowing needs rather than on communication and interaction needs as well.
Okay, and Catherine Needham, you can say more if you like, because you wanted to know a bit more about the staff, about roles and seniority. Was there something in particular you wanted to know about staff roles, Catherine?
Well, just a bit to give us a bit of a sense of kind of who were these staff, you know, to what extent they had any kind of medical training, just to sort of help me understand that a bit more.
Yeah, no, so these were support workers, and so they were primarily I don't know what the right terminology is to use. They were working in frontline positions rather than in managerial positions. We particularly wanted to talk to the people who were working and interacting every day. So I do have information on people's qualifications. Most people would have been would have finished their education at school level. There were one or two people who had degrees, but most people didn't. So their training would have been in-house training. Lots of people, when we talked, one of our questions was why did you decide to work with people with intellectual disabilities? And lots of people said, well, you know, I'd worked in the building industry, or I'd worked in catering, and I lost my job and I needed another job.
Okay, thank you. Anybody else who hasn't put something in chat who'd like to ask a question? Got time for another one? Wave or just speak up. Can I ask Jill just about the observation, which is sometimes quite difficult to organise and do, but often really illuminating, as you mentioned. Was it straightforward to organise and do? Did you find any particular challenges in sorting out that part of your research?
The staff and the services were so welcoming and were so willing for us to go and observe. We obviously we talked to people about when it would be better for us to observe and made it clear the things that would not be appropriate for us to observe, but people were really very happy for us to be able to go and do that. Was that your question, David, or was it more about the methods?
No, I just wondered. I wondered how how kind of easy or difficult it had been to set up and to do. And
yeah, we had some service users who withdrew from the study, which although we were sorry to lose them obviously from the study, I think it's always positive when service users are unable to say no. And I think in one case that was because the person didn't want to be included in the observations.
Okay, and just finally, where can people find out more, Jill? Are the findings on the SSCR website, or you have a paper out?
So I have a couple of articles that are not quite there yet, and I had a look this morning, but I don't think the final report is up on the SSCR website, although it has all been signed off. So, but I'll defer to Angie on that one.
She has just messaged me privately to say that the findings will be on the website in about 2 weeks' time. Okay.
Well, ask me the question again, David, and I shall reply in about 2 weeks' time.
Brilliant. Thanks, Jill. Thanks very much indeed. And
thank you.
We're going to move on to Sara Ryan, who is talking about a project which I think is just getting underway. So welcome, Sarah. Thank you.
Thank you. I've got a slide. Somebody doing my slides, sorry. Failed, cone of shame on sharing my slides myself. So yeah, thanks for inviting me to talk about this project. It started in June. And what we're going to do, or what we've started doing, is to try to bridge the translation gap between learning disability policy and practice. And I think that Jill's presentation just now is a lovely, though sad, depressing example of this gap that remains. So next slide, please. So we're going to use a capability approach here to try to get beyond the malaise surrounding the inability to support people to lead flourishing lives. And the premise of the study is that the focus on choice, autonomy, independence isn't working. People are still leading far from flourishing lives, and quite often much worse. One of the premises of the study is that the bar of what is acceptable care is too low. For example, the CQC inspection criteria has got 5 domains: safe, effective, caring, responsive, and leadership. And the definition of effective, if you look at the CQC website, is your care, treatment, and support achieves good outcomes, helps you to maintain quality of life, and is based on the best available evidence. Now that is so woolly in terms of trying to interpret what that means for CQC inspectors that I think too often, if you read CQC reports, and it has become a bit of a hobby of mine, is that if somebody's well fed and safe and clean, then the provision is judged to be good, even if there's only 2 members of staff on a weekend and nobody can go out. So I think there's a real failing here in terms of the lenses we're looking at, what people are expected, the sorts of lives people are expected to lead, and what good is. So a capability approach hasn't been used in social care research much at all. I'll come back to the odd study there is. And it might, I don't know, and I appreciate Jill saying that you felt your study failed. Obviously it didn't, it still contributed to our understanding. But I'm hoping that using a capability approach may help us to sort of shake things up a bit and look differently at what is happening in order to try to work out how to do things differently. So what is a capabilities approach? Well, it was developed by Amartya Sen, an economist, and it's been sort of run with various people in various directions, which is great, which means it's a totally flexible approach. And Martha Nussbaum probably is the most relevant runner with this approach for our study. The sort of core of a capabilities approach is based on two claims. One, the freedom to achieve well-being is of primary moral importance. So it's really about freedoms, the freedom to be able to do things that you want to do. And this, the second point is, this is understood in terms of people's capabilities, which is their genuine opportunity to do things and do what they have reason to value. And so it's about genuine opportunities. And I think, again, Jill's study really highlighted how, you know, if you're not able to, if people aren't able to communicate what they want to do, they have no genuine choice or opportunity at all. You know, that's just dead in the water, basically. So that's what a capability approach is. Generally, it's a flexible, multi-purpose approach framework. It's an approach rather than a theory, although you can take a theoretical approach to it. At the centre of a capabilities approach, which is what speaks to me, is that human diversity is a core feature, and it's underpinned by social justice. And I think those two factors, human diversity and social justice, should be the key defining features of any examination or scrutiny or research involving people with learning disabilities, because the situation that they live in is as I've already alluded to, is pretty poor. So a capabilities approach adds informational riches, which is lovely. It can sort of reveal dimensions that are overlooked by other approaches, because it is looking at it in a slightly different way. And even though we've only just started this study, Siobhan Russell, the researcher, and I are forever sort of like, you know, we sort of talk about things and then we sort of take a step back and sort of put our capabilities lens on and start to sort of try to understand things differently. So let's have the next slide so I can just give you the core concepts in a capabilities approach. So you have four separate concepts here, and the key ones are the functionings and the capabilities. So the functionings is what you are, your beings and doing. So what you're able to do, what you've achieved, what you do. And your capabilities is the opportunity. So the functionings are the realised capabilities, if that makes sense. So you have what you can do. The people in Jill's study sit and watch the telly. That's your being and doing. Your capabilities may be that you wanted to go and go for a walk in the woods, but that they don't have. The people in Jill's study didn't have those capabilities. They didn't have the freedom or the opportunity to the actual genuine freedom or opportunity to do the things that was important to them. And so what they're left with is watching the telly and doing very little. And then alongside these functionings and capabilities are the means, which are the resources available to the person, which will bring in all sorts of different, like your demographic factors, what sort of access you have to different sort of money, whatever the resources you have. And then you also have conversion factors, which is your personal, social and environmental factors that help or hinder your ability to transform your means into functionings. So that's the core concepts of the capability approach. And as I said, the difference between functionings and capabilities is what is realised and what is effectively possible. And already you can see, turning this to a learning disability arena, there is a vast gap here between what people are doing and being and what they may well wish that they could be doing. So some of the key questions, because there's an awful lot of discussion if you dive into the capabilities approach literature, which is used often in development studies, all sorts of different disciplines it's used. And some of the key chewy issues are, because it's all about people's well-being at the heart of it, should we be focusing on functionings, because that's what people are doing? So should we be measuring people's actual well-being, or should we be looking at their capabilities? And this is quite a thorny issue here. And then if we decide we should be focusing on capabilities, which is what we've decided in this study, which capabilities should we be focusing on? And again, this is a useful lens in this area of study, because it allows for people, what I may want the freedom or opportunity to do would be very different to what one of my mates at My Life, My Choice would want the freedom and opportunity to do. But what this approach does is allow value to be attached to whatever anybody wants to do. So it's not a pejorative, well, you can't do that because that's not good for you. It's actually recognising that what people want to do and what is of value to them is important to them. So it's got this lovely individual focus too. So if we have the next slide, which I hope is the next, yeah, oh it is. Sorry, that's got a bit squidged up, hasn't it? Sorry. Martha Nussbaum, she's come up with this core central human capabilities, which is 10 capabilities, which you can hopefully just about see there, which she says are the basic, this is what every member of a society should have the freedoms to have health, to stay alive, to be able to sort of have sexual relationships at the same time as not be sexually abused. There's all sorts of these core capabilities that Nussbaum's come up with. So I've just put them there for a moment because I want to come back to this in a bit. So these are very sort of, this is quite a contentious list. If you go into the literature, you'll find that there is sort of some discussion around what is this useful, this list, what does it do? But I do think it's quite a helpful starting point in terms of thinking. And then if we go on to the next slide, I mentioned that the approach has been little used in social care research, and there is a study by Gupta and Featherstone. Sorry, can I have the next slide? Oh, I'll just carry on. Oh yeah, so we've got this paper here, which is Gupta and Featherstone from a few years ago, where they used a capability lens to look at safeguarding processes involving children. And they raised the issue about capability failures, that you can identify, using this lens in social care, for example, you could identify capability failures, and then that allows you to try to identify the relevant causal pathways responsible. So part of our study is going to be looking at capabilities, what's important to people, and then we're going to be going to the front line to try to work out why is it that there is this gap still between what people would like to do and what they're actually able to do. And then the next slide, please. There's a key figure. Ingrid Robbins is quite an interesting character because I think Amartya Sen was her PhD supervisor. Little snippet of information there, and she's sort of like really is wedded to this approach, and she's pulled together a book called I think it's called Social Justice and Capability Approach, where she's tried to get rid of the white noise that's confusing this approach and is making it quite tricky for people to use and pin down what it actually means. But one of the studies, or one of the things she's done is turn this lens onto whether or not a capability approach works for autistic people. And she was suggesting in this, what she was asking in this paper was, do we need a separate account of well-being for autistic people? Which is a really interesting question. And then she also asked, and if we did, what philosophically would that separate approach add to the, what could people learn? What could the, say, Martha Nussbaum's 10 capabilities, how could that be enhanced by understanding what autistic people would benefit from in terms of a capability approach? So she concluded that Nussbaum's list didn't include this importance being free from sensory overload. She felt it didn't include that autistic people really should have the opportunity to be understood. And she said as well that autistic people should have the freedom to be loved and cared for, which was interesting because you could interpret Nussbaum's list to include some of those things or not. But her argument was, which I loved, that there should not be a separate list for autistic people. Of course, there shouldn't be a separate list for autistic people. There should not be a separate list for people with learning disabilities. We're not in the process of othering here. We're in the process of making what is the mainstream more flexible and more wholesome and inclusive to capture everybody's capabilities and everybody's freedoms. So she suggested that possibly the list should be widened, because the consideration of the issues that are particularly relevant to autistic people are, of course, particularly relevant to lots of other people. And as an aside here, we're coming back to Chris Goody's inclusion phobia. I don't know if many of you have come across that, where his argument is that it's because we are all inclusion phobic that we have this othering of learning disabled people. We're actually creating divisions to push people away. And in fact, we shouldn't have to be talking about different types of people at all. We should all be people. And this is at the heart of the capability approach, is this humanness, the inherent humanness of us all. So that was really interesting. But the other point she raised, and if I could have the next slide, it would be really helpful, thank you. She asked questions about what was the intent, how are people who may not be fully independent and need support, how is their support being constrained by the people who support them? So if we have a look at the next slide, she's asked 3 key questions here. She's sort of suggesting that sometimes some constraints on people's freedoms are necessary, because you might want to constrain someone's freedom like a child's freedom when they're growing up, in order for them to learn how to have a more flourishing life when they're older. So you may make your child do their homework, for example, even though they want to play Minecraft all the time, because you're sort of, you know, it's like a delayed freedom. But when people are adults, she's saying that obviously, and we heard this, Jill's study illustrated it beautifully, the constraining of options by support workers or family carers. What does this reflect? And she says what we should be asking, does it reflect a genuinely well-informed attempt at improving the flourishing of the person? And I think we can probably agree that apart from the one person, Jill's 4%, that isn't a reflection of Jill's study. Is it a well-intended but poorly informed attempt? That may be the case for some of the staff that Jill was talking about, and may not be for others. Or does it reflect prejudice and or an inability to respect the person as an autistic person? Sorry, I missed that person. Or put their interests central. And I think we probably would, if we had to sort of put our money on it, we would go for number 3. So I think it was really interesting that when Robin's turned her attention to the to autistic people, she's raising really interesting and important questions that we will be chewing over during our study. And I think it was a nice endorsement for the approach we're taking. So before I go on to the next, just a tiny bit of detail about our project, which has only just started, I wanted to flag up these 2 studies, which are brilliant and were published in the last couple of weeks. And first of all is Sally Warren and Paradigms Don't Call Us Unskilled Again, which is a lovely pandemic focused exploration of how support workers have been doing their jobs during the pandemic, and coming to this conclusion again that support workers are not unskilled workers, and they should never be considered unskilled workers. And the people who are on the building site or working in catering who have gone to a caring role, a support worker role, you know, we really need to sort of sort out how that role is presented and how that role is actually done. And there was in our background to getting this research funded was 2 recent reports by Dougal and Mouser and Bowers, which highlight the importance of transformational change by frontline workers who are in a position to see the cracks that other people may not see. Even the managers of a service may not see what is the problems, what are those obstructional happenings that stop people leading flourishing lives. And I do think that actually for a support worker, and I've seen this in different countries where you see support workers and people that they're supporting, where they just go out and have fun and have a great time. And certainly our son, he's volunteered and worked for a local charity and he loves it. They all have so much fun working with young people, and a lot of it he doesn't even see as work, because they just all go out and have a good time and sort of just enjoy themselves. And so that's what we really need to get to, is rather than sticking people in front of the telly. So there's these 2 studies, which is great, and the self-build study by Andrew Power and his team down in Southampton, again, is a lovely study highlighting how it's the small building blocks of care we should be looking at, the importance of self-advocacy and these tiny sort of steps that we should be taking in order to build really, really good lives for us all. So this was lovely timing for us, because we're sort of using these 2 studies and in our work as well. So next is our team, I think. Got a slide with our team of riches, which is really cool. We've got Angela Vade, a family carer, and Stuart McMurray, who's an expert by experience, for the want of any other term. We've got Charlotte Goss from Bradford Council. We've got the Point of Care Foundation. They're going to be publishing some of our outputs. We've got Sally Warren, who published that study I've just mentioned. Elaine James, who's a commissioner at Bradford Council. Rachel Forrester-Jones from Bath. Jackie Fletcher, who's a director of Dimensions. Siobhan Russell, I mentioned, is the research on the project she started with us a few months ago. Louise Lowcock up at Aberdeen will be leading on the learning community part of the work, and Angela Martin is going to be project managing, and I'll be working on it too. That's the team. Thank you. What are we going to do and how are we going to do it? Well, first of all, we're going to review what's known about good support and produce a list of components of good support, which will be a bit like Martha Nussbaum's list. What is important to people? What does the literature and the grey literature tell us about what's important to people? Then we're going to take that list and we're going to run focus groups and interviews with people with learning disabilities and family carers to talk to them about what's important to them, what do they think is important to their daughter or son, how does what they think is important match with the list we've got, and we're going to then come up with a sort of core set of what is important to people, and we're still chewing over this functionings and capabilities distinction within this. The third part of the study is to run a learning community, which is going to involve 6 care providers, support work providers. 2 have already agreed to sign up. We've got a small local provider who we know it's brilliant, and 2 national providers have already agreed to take part, and then we're going to find some other providers based on our public involvement group. And there is evidence that we can draw from in healthcare that bottom-up engagement in person-centred improvement, as they talk about in healthcare, is incredibly motivating for frontline staff. So we're going to run this community for several months and do all sorts of observations and things to try to turn a lens of thinking differently about support and how people are supported, because our hypothesis, not that we've really got a hypothesis, is none of this stuff is pricey to do. It's all about shifts in how you approach things and how you feel about things. So that's our plan, and at the end we're going to produce a Flourishing Life Guide, which we publish on the Point of Care Foundation website, and then we're going to take this guide on tour and wave it under people's noses, including the CQC and other people, and sort of shake a flourishing life stick at people. So that's our plan. And then I think my 2 more slides. Public involvement. We've got Anjali, who is running, she's pulling together a group of people, including Stuart, who's a second co-applicant. We've got people up in Bradford that Charlotte's found for us, and we've got 2 parent carers as well. And this team, we're doing some training for Anjali, Stuart, and a couple of other people on other projects I'm running at the moment to enable people to take part in research in terms of being part of the research team. And then we've also got other research plans around producing easy read documents and that sort of thing. So it's very much a sort of quite a dynamic project with lots going on. And then I just wanted to finish, because I kept time, with one last slide, which just out of interest, because we're, Siobhan sort of pulled together what these components of good care are going to look like already, and we're just sort of still discussing it. But what's really interesting is we mapped this against Andrew Power's findings, and there was quite a lot of similarity, and then we mapped it against Martha Nussbaum's list. And we found that the only thing we didn't have any evidence for, and Siobhan's checking, so she may have changed this since I spoke to her last, was there was no consideration in the existing literature around being in nature, being with animals, being outside, which is a really interesting gap, because certainly the people I know, a lot of people I know, are incredibly soothed by animals and by being outside. So I thought that was a very interesting gap that we've already identified. So that's our project. Thank you.
Thanks ever so much, Sarah, and for keeping to time, and really clear, interesting description of what you're doing and what's to come. So thank you. I'll take Yvonne's question in chat, and then open up to any other question. Yvonne was just asking, Sarah, if you had any thoughts on why this approach perhaps has featured so little in social care research. Why have we seen so little of it?
My guess, and that's a really good question, is that social care research is, certainly when it comes to learning disabilities, beleaguered by this malaise that we all fell down the valuing people hole and sort of thought the answers were autonomy, choice, independence, and everybody's run with that. And we've not really been innovative enough to sort of look around and think, well, there might be some other ways of looking at this. And I do think part of it is this, there's a terrible acceptance of the lives people lead. And we're sort of tinkering around, we're tinkering in places without actually thinking, hang on, we need a fresh look. This may come to nothing. I may be talking about this project in a year's time, or Siobhan maybe saying like Jill, so we thought this was going to sort of produce this finding or not. But yeah, I just think we just need to shake up, and I just think we need a bit of innovation, really, a bit of left thinking.
Great, thank you. And I think Catherine had a point of information about work going on at Birmingham. A health economist developing an outcome measure based on capabilities called IceCap.
Yeah, it's been out for a few years, so it's all kind of freely available. You know, it's all about giving a score to how you feel about things, and maybe that doesn't fit with kind of how how capabilities is considered in a rich way, but it might be of interest.
Oh, good. I'll have a look at that. Is that ICE as in ICE cap?
Yeah, IceCap. Okay. Yeah.
Oh, I'll have a look. That's really useful. Thank you.
Thanks, Catherine. Anne-Marie was just asking about the timescales for the study, how long it is, and what will happen next.
Yeah, we've got, I think it's a 26-month project, and we're already delayed on ethics. So I've got 2 or 3 projects that will start at the same time. So we're going to do a bit of fudging on timetables to get people working on different bits. But the plan is the components should be finished anytime now. And then we should be starting the fieldwork, which will obviously have to go online. And we're just working through ways of doing focus groups online and how to engage with people. So we're looking at that. And then we're hoping to have the learning community start in March for 11 months. And the learning community will meet 3 times in person, or hopefully in person, across that 11 months with a password protected forum bubbling away in the background. And we're expecting 6 providers will sign up to teams of 4 to 6 people, mostly support workers, but with some management involved too. And so we'll have these 3 meetings and sort of really thrash through, have a really safe space for people to say exactly what they think about what support they provide and what they feel hinders them. And hopefully we'll be getting the examples of brilliance that I mentioned. Some of the Yellow Submarine Charity in Oxford, for example, have got a real just get on with that attitude. So we want to have some people who've nailed it in the learning community too, and then have discussions in between the meetings to sort of talk through how it's going, raise questions and all the rest of it.
Brilliant.
And then 3 months of the Flourishing Lives Guide, and then on tour.
Oh, great. Thank you. Martin, did I see your hand up?
Yeah, just quickly. So 2 or 3 things. One is to thank Sarah and Jill for really these webinars. I don't know why there aren't millions of people watching, because they're so interesting and informative. So thank you for that. I mean, really very, very good, both of them. I mean, on Sarah's one, I'm probably the oldest person on this call. I was a student of Amartya Sen's once before he was even a professor. So there we are. About 140 years ago. But I think the approach is really interesting. I didn't know about the what's her name, Robin's her paper at all. So that sounds really interesting. So thank you very much for drawing attention to those. There are 2 of the people who are supported by SSCR are trying to explore capabilities approach for their work. So Camille Boo, who's a PhD student, is interested about using it to help to understand the well-being of young carers, but it's not the dominant sort of approach she's taking. And then Josie Dixon's been exploring it a little bit in relation to end-of-life care, but not quite as head-on as you are. So I think, and I did check, neither of them are on the call, but I'll make sure they listen to this afterwards, because I think it'd be really helpful to have the contact. And I just think, both the projects that we've heard just show how important SSCR is in both doing, Jill was talking very practical things, but set within a very clear conceptual framework. And Sarah's been sort of testing our brains to think, more broadly about the underlying conceptual things. I think it's really, really useful. So thank you very much to both of you.
Thanks, Martin. Sarah Donna wondered is there going to be a project website? She'd like to share more information about the study. How could she do that?
Oh yeah, no, that's a really good question. We're going to have a Twitter. We've got a Twitter. We haven't quite gone live with this yet, but we're having a WordPress website, which we're going to be throwing out our ideas and trying to generate a discussion as we're going along, which would be great. We're going to have a Twitter account, which we'll be tweeting about what's going on, which is called 4 Flourishing Live. because we couldn't. Flourishing Hearts is all over Twitter. And I should point out that the project logo, which is beautiful, is done by an artist with learning disabilities, Susie, and that's part of Sabah Salman's Happy Gallery of artwork, crowdsourced by, she's a journalist and she's crowdsourced work by learning disabled people, and she's got a gallery online which she's very happy for you to approach her, and she'll approach the artists if any of you want to use interesting and lively artwork for your projects.
Great, and Angie has just put in chat a link to some of the information about the project while the project team is setting up their own site. So there's a link there in chat to the SSCR information about the study. I'm going to wrap up because I see it's 1 minute to 2, and just to echo Martin's thanks really to both speakers. Been really interesting, learnt a lot, and thanks ever so much for everyone's participation, and thank you very much for joining in. The next SSCR webinar will be on the 1st of September on the topic of end-of-life care. But thank you everyone, and have a nice afternoon.